My name is Fitzhugh Mullen. I'm a pediatrician and health policy expert. I'm a professor of health policy and pediatrics at the George Washington University in Washington, D.C. The origin of Medicare paying for residency is really in the original act in 1965, where there was a phrase to the effect of, and Medicare will address educational expenses, by which they meant residency, until the community sees fit to do so. Never clear what community was supposed to do what, but that was the keys to the kingdom, as it were, in terms of residency being covered by CMS. At that point, residents were virtually not paid. It was considered a minor consideration, if at all. It was really 1983 with the prospective payment system in Medicare that began at that point, where hospitals were paid on a per-case basis based on the cost of clinical care. And they said, yes, but what about the residency obligation? And HCFA at the time, Medicare at the time, said, yes, we'll pay for that. That'll be the cost of the resident's salary attributable to Medicare, as well as teaching time. And the hospital said, yes, but there are indirect costs, there are other costs. We know the teaching hospitals are more expensive, and they gave at that time and have given over the years a variety of attributes associated with teaching hospitals, standby units such as burn units and care for the uninsured, residents are slower, et cetera, none of which has ever been a tight case, but it was a case for indirect payments. And Medicare said, we'll pay that. And when calculated from the beginning on, the indirect payments were set at a rate that is double the direct payments. So that for every dollar they pay that you can track for a resident's salary or the teaching time of an associated attending physician, they pay $2 for indirect costs, which of course has been the most generous and probably most important from hospitals' perspective amount of money. Today that adds up to about $10 billion a year, divided by the number of residents in the United States. There's a little over 100,000. It comes up to something on the order of $110,000 per resident per year. There is certainly an enormous amount of education that goes on in the preparation of residents in general. It varies a great deal from setting to setting and from specialty to specialty. But the teaching burden on teaching hospitals of bringing residents from medical school, where they're at best smart learners or smart starters, to folks turned loose with licenses to perform all manner of medical service, is quite an extraordinary feat. And that goes on in the teaching hospitals of the country every day, every year. That's good. Medicare pays for its portion of it. That's about a third of the bed days. I think a question that's more pertinent really is the money that is paid by Medicare for residency education dedicated to education. And it is not much of it. Now, the indirect cost is a hospital payment that undoubtedly helps the hospital, but it really is not linked to the number or the, it's linked to the number, but it's not linked to the type of resident, as in specialty, nor the geography of the hospital, nor the career intentions of the resident, all of which are important factors in today's workforce development. We have states and areas, as well as specialties that are underserved, undersubscribed, underpopulated, and others that the reverse is true. And one could argue, one does argue, I certainly do, that federal money of this magnitude going into residency ought to play a role in encouraging certain kinds of outcomes and perhaps discouraging others. There should be some prioritization or ability to use that level of federal support, $10 billion, to help shape an outcome in terms of the profile of physicians in the country that is judged to be in the best common interest or the national interest. The Teaching Health Center program is born of a new concept. Because of Medicare payments, residencies have largely been locked down in hospitals. By and large, hospitals do not receive the Medicare payment unless the resident is on their premise. premises. Today there's some flexibility in that, although it's minimal. So that if a resident should want to be trained, or should the hospital or the community want to see them trained at a different facility, a private facility, a private doctor's office, or a community health center, or a public health office, etc., these are not really reimbursed, and therefore they're discouraged. So particularly in regard to community-based primary care, we know today that a great deal of medicine, certainly in primary care, is taught, should be taught in context, in settings where doctors will be practicing. Yes, all physicians need hospital rotations, hospital training, but you can do just the flip, have a physician community-based for training, who then rotates to the hospital for their inpatient experience and back to their base in the community. The idea of the Teaching Health Center program is to promote community-based teaching, particularly for rural practice, those interested in rural practice, where that context is really what they need to learn in terms of their careers. Inner city practice, or practice with special populations, many ways in which residents can learn better in community-based settings. But in order to do that, you had to have a funding stream that would place residencies in communities and allow the community leadership of the health center or the leadership team at that medical institution to set the agenda of training, as it were. And that is what the Teaching Health Center program does. There have been 60 sites funded around the country, about 45 of them in family medicine, but 8 or 10 in internal medicine, a few in pediatrics and other specialties. So the question was, when the legislation was originally introduced, at what rate should the government pay for the teaching and teaching health centers, for the training of residents? Because all the data we have is based on hospitals, and it isn't really related to what the resident actually cost. It's related to complicated formulas based on the hospital's size, the intern and resident per bed ratio, and a variety of other things that do not pertain to a community-based setting. So the level was set at $150,000 a year at the outset, with the requirement for a study to see what indeed community-based education cost, medical education. This is in a context where the actual cost of medical education received very little attention over the years, unfortunately. So we set about determining the cost in these communities to the health centers of the residency training. We looked at the cost of the resident and the teaching time of the senior physicians who worked with the residents, as well as other related costs. These would include things like the facilities cost, the cost of having examination rooms, having backup personnel, or having ancillary personnel, having laboratory facilities available, as well as other related costs such as malpractice insurance, on-call rooms, and what have you. Packaging that all together, it came out with a fair degree of consistency across programs in inner cities, in rural areas, and the like. And that hovered ultimately in the area of about over $200,000. That's the cost. But what we also took into account, which is not usually taken into account by Medicare or others, is that the resident actually makes money for the facility. First-year resident, much less so, because they're much slower, much more supervision. But by the time the person is an advanced resident, a third or fourth-year resident, they're very efficient. They're prepared to go out and practice on their own. And for their facility, in this case, community health centers, but same could be said of hospitals, they actually are quite productive in terms of seeing patients and having those patients billed for. Now that came up to something variable depending upon, this is much more variable. Established health centers that had training programs before were very efficient, and those residents in those settings made a good deal more money, on the order of $110,000 a year for the center. New centers that really were having residencies for the first time were less efficient and collected about half that over the course of a year. So the revenues were dependent on the maturity and seasoned nature of the center, getting better all the time. The costs were fairly consistent across the centers. And when you put those numbers together and asked what it really cost, it cost a little more for new centers than for continuing centers, but it hovered around $150,000, the figure that was set as an arbitrary, evidence-based, but arbitrary figure at the beginning of the program several years ago. Well, this, of course, is the most important question. Will this do what it's intended to do, which is increase the number of doctors in areas that are chronically short of physicians? The answer seems to be yes. Certainly the data is all promising. First of all, entry surveys of individuals selecting these programs indicated a high career determination, career intent to practice in the community or communities like the one in which they're training. Now, on the one hand, you might say that's obvious. They've picked a setting like this, and I think that's true. But here you're taking a person with intent, with mission. You're reinforcing that mission, giving them excellent education in the setting in which they want to practice. Surveys of exiting residents, which we now have a set of, and there are only a couple of years that are out in practice, so it's hard to say long term, seems to indicate that that resolve has remained or been intensified, that their intents on leaving residency and going into practice are to stay in those communities or ones like them, be they inner city, be they rural, be they challenged in whatever way they are. So we think that this is a terribly important opportunity, really reform for medical education, where a good deal more of education can be done in community settings, extramural as it were, outside of the hospital, particularly in the primary care disciplines, and certainly in others. And by primary care, we have several dental programs, geriatric programs, as well as pediatrics, medicine, family medicine, a psychiatry program, and a couple of OB/GYN programs. So it's not limited by any means just to family medicine. This principle seems to be holding up very well across the disciplines. And in an effort to transform healthcare in America, where we'll have a more equitable distribution of physicians and better access to all communities, we think this has an important message and an important future as an adjunct or additional way to do medical education. Nobody's saying that hospitals shouldn't remain the base for specialties of a variety of sorts, but a much more prominent role for community-based education is really the mission of teaching health centers, and we think they're proving it.